afternoon, everyone. Welcome to this event this afternoon. My name is Colin, Tukuitonga. We brought the stars out for you this afternoon. So welcome, everyone. Tēnā koutou katoa. I'm just going to start our discussion with a short karakia. Pakataka te hau ki te uru, pakataka te hau ki te tonga, kia mā kina ki uta, kia mā taratara ki tai. He hi ake ana te atakura, he tio, he huka, he hauhu. Ti hei Māori ora. Thank you very much again for joining us this afternoon for this webinar, Tools for Equity, Addressing Social Determinants in Aotearoa and the Pacific. I know it's not very fashionable or politically fashionable to talk about equity these days, but there's even more reason why we should continue these conversations. So you're very fortunate. We've brought out the stars, as I say, and so we'll get underway. Our first speaker is Dr. Sudhvir Singh. Sudhvir is a physician from Aotearoa, a graduate of this faculty. As the unit head for equity and health at the World Health Organization, he led the development and launch of the World Report on Social Determinants of Health Equity. We're delighted he's actually here with us. He's on parental leave here at home. So let me invite Sudhvir to make his statement. Thank you.
Kia ora koutou. Thank you so much, Sir Colin and the school for hosting this. And it's so nice to be home and to be back at the school. A lot of fun memories here and to see so many familiar faces who have taught me over the years, also part of this session. So it's a real privilege to be back, and thanks for joining. And yes, very grateful for the chance to share this work with you all. So in terms of the WHO World Report that was launched this year, why was this report launched? What was the background? Well, at the peak of the COVID-19 pandemic, it was evident that the impacts were deeply inequitable, both between countries and within countries, between social groups within countries as well. And also that pre-existing inequities were making the pandemic worse for everyone. And against that backdrop, our member states came together, including New Zealand, and called for greater technical support to address the social determinants of health, including through an updated world report that would synthesize the latest evidence and put forward concrete policy recommendations. The most recent global report before this one on these topics was the final report of the Commission on the Social Determinants of Health, which came out in 2008. And that was a very sentinel piece of work, but it's obviously been a number of years since then. So we started the World Report by looking at some of the data and trends on health equity since 2008. And we've got a lot of great speakers on the panel today, so I'll just be very high level and brief here in my overview. I hope you'll get time to look at the report in detail because it's full of rich information. But in summary, on the data side, between countries, we are seeing a gradual narrowing of health inequities, albeit at a rate that's insufficient to meet the targets that the Commission set. But what's really concerning is that where we have data and we look at what's happening between social groups within countries, health inequities are often getting worse. And that's whether we look at population groups based on their education levels or their income levels or race, ethnicity, we appear to be going backwards, despite all the evidence and despite the acknowledgement that this is a real problem for societies. And so that's deeply worrying. So why might that be? Well, then the report then looks at key data and evidence across social determinants of health. And we really try to focus attention upstream at the structural determinants, and we try to modernize this concept of structural determinants of health. And I'll go through how we have said about that. First, we look squarely at economic systems. And we notice that within economic systems, income inequality is concentrating, is getting more intense, particularly within countries. So we're seeing a similar pattern to what we're seeing with health health inequities. We're also noticing that wealth is becoming more concentrated. At the same time, fiscal space for countries is under significant pressure. Tax systems are underperforming. Still around half the world's population go without any type of social protection coverage. And we know that social protection is fundamental to population health. We notice that debt distress is also intensifying. So the world's poorest countries now spend 4 times as much on servicing their debt than 10 years ago. And that's at the expense of investing in key social determinants like education, like health. At the same time, we recognize that climate change and conflict are also intensifying. 2024 had the most conflict recorded in the world since the Second World War, and it was also the hottest year on record. And together, this has resulted in a tripling of forced displacement in the last 15 years. And we know that people living in conflict settings have the worst health outcomes. So pulling this together, what is the diagnosis? And most importantly, what can we do about it? Well, the report draws attention to these structural determinants that stratify people and social groups and shape daily living conditions. So we look at economic systems, as I mentioned, so taxation, the way markets operate, but crucially also this concept of the commercial determinants of health, the role of the private sector and corporations in health. We then look at social infrastructure, which we define as the policies, services, and places that allow people to fully participate in their societies, and how societies have to adapt to forces like urbanization and demographic shifts. We recognize that too often discrimination is embedded in institutions, in norms, and in policies, including the intersection of structural racism with gender inequality and discrimination based on class, sexual orientation, age, and whether or not you have a disability. And here I want to acknowledge Professor Paparangi Reid from the faculty, who was on the scientific advisory group for the World Report, and whose guidance really helped us understand how structural discrimination really shapes health outcomes, but also what we can concretely do about that. We observe how the world is being fundamentally reshaped by mega trends like climate change, like digitalization. And big thank you to Dr. Kirsty Wild and Professor Alistair Woodward, who's on the panel, who really used their expertise to contribute to a background paper on climate change and health equity that then allowed us to really be up to date with these topics in the report. But we're bringing in climate change as a key social determinant within the framework now. And unless we recognize and address these underlying structures and trends, the report concludes that we'll always be playing catch up when it comes to improving population health and health equity. But the report isn't just about a diagnosis. So the majority of the report, all the chapters from chapter 3 onwards, focus on the evidence behind concrete actions that will improve health, reduce health inequities, and how we can learn from and be inspired by action taking place already all over the world, in countries and in cities and in communities. And so the majority of the report is focused on solutions and how we go about implementation. So for example, one concrete example from Aotearoa is we're very pleased to feature the 2024 evaluation, 5-year evaluation of the Healthy Homes program from Tukuitonga Ora, which showed that these interventions improved school attendance, reduced hospitalizations, particularly for Maori and Pacific families. And so that's then in this World Report as a case study. And I think maybe if we have time, the panel might reflect on, I understand that some of these policies are not being emphasized as much currently, even though we have evidence that they work. And why might that be, and how do we navigate that? So clearly, just having evidence that something's effective isn't enough to necessarily sustain them. So bringing it all together, what does the report recommend? Well, the report concludes with a chapter on governance for health equity, making sure that health and equity are at the center of all government decisions, not just in the health sector. So the report has 4 action areas, 14 recommendations, and a series of key actions under each recommendation, which you can look at in detail. Let me just summarize some of the main recommendations. We focus on the importance of progressive taxation systems to invest in universal public services and social protection. We want to see progressive taxation, so that's where the wealthier contribute proportionally more to invest in key services. Expanding social protection coverage is a major element of the report. Elements such as sick leave, child benefits across the life course. We have a whole section on the commercial determinants of health, how we must address conflicts of interest in policy environments, how we must regulate health-harming industries, as well as supporting the health-promoting capacity of the private sector. And I look forward to Boyd, who I see on the panel, can perhaps share some insights on how we might be able to practically do that, given all the work in the trenches that Boyd is doing. We also focus on how social determinants of health must be protected in emergency and conflict settings, not just in times of stability. How we can harness climate action and digitalization for health equity so that we can accelerate climate action and ensure that digitalization works for health equity, not against it. And in conclusion, some other key recommendations: the role of local authorities, local government is crucial. There was a major conference last week in Wellington on this, and Alistair was there, so perhaps we hear some insights. But we know that the local authorities have a much easier ability to work multi-sectorally. They're closer to their communities. There's such critical interventions in areas like housing and transport and urban planning that we must learn from and implement. Linked to that, the importance of independent civil society, of community engagement. How those most affected have to be at the heart of decisions being made, and how we need to support and learn from grassroots action. Of course, as a WHO report, we emphasize as well the importance of achieving universal health coverage, particularly through a primary healthcare approach, ensuring that everyone can access key quality health services and health technologies without financial hardship. And to do that, we need a well-supported health and care workforce, something that's being worked on so deliberately within these walls here at the Faculty of Medical and Health Sciences, and a workforce that walks the talk on equity. We have significant discrimination, for example, within our ranks as a health and care workforce. So how can we be proactive in addressing that? Finally, the importance of data, research, and monitoring. Good decisions require good data. So we call for better monitoring of health equity to inform policy, to track progress, as well as a focus on implementation research. So we're not just kind of mapping out these inequities and these gaps, but actually learning from and informing policy action on how to address them. And I'm really grateful that Corina will hopefully be joining us, and he played a very central role in this report that he can elaborate on as well. So now we want to see these recommendations discussed, adapted, and implemented. It's great that the Public Health Advisory Committee, I see Kevin on the call, has gone about what is essentially a sister report, and we were coordinating during the development of both reports. So I look forward to hearing about that and how we learn from each other to figure out how we can best make progress. So thanks once again for hosting. It's wonderful to be here, and I'm looking forward to a rich discussion.
Thank you very much. Thank you very much, Dr. Singh, for that presentation. Let me just invite, we may be lucky to get to answer some questions at the end. So if you have any burning questions, put them in the chat and we'll see how we go. Thank you very much, Sudhvir. A pleasure now to introduce Kevin Hague. Kevin is a long-standing public health advocate, former CEO of the West Coast DHB, the Royal Forest and Bird Society, and the New Zealand AIDS Foundation, and a former MP. Chair of the Public Health Advisory Committee. Not sure if you're still the chair, Kevin. He pretty much led the recently released report Determining Our Future, offering a blueprint for strengthening public health and equity across Aotearoa. So I hope you can see that we've moved from the global to the local. So Kevin, welcome, over to you.
Well, kia ora, Colin. Kia ora tātou. Thanks for the introduction, and great to see you in Aotearoa, Sudhvir, and to listen to that presentation. Yeah, it's interesting. The WHO and New Zealand's Public Health Advisory Committee had the same thought at the same time, that it was timely to review our work on determinants. And looking back over the years, some of you will remember that Ron Labonte was both instrumental in that earlier work for WHO and was a very regular visitor to Aotearoa through the 80s and early 90s, contributing a lot to our thinking. Colin, I am no longer the chair of the committee. My term was due to come to an end this month. And when I searched the auguries, I was fairly confident that I was not going to be reappointed by the minister, and so stepped off the train to take up another role that was incompatible. So I find myself back working in the parliamentary environment, where I'm trying to pursue the same causes by other methods. So I'm no longer a member of the committee, and indeed the committee's membership is changing this month, we believe. And that means that I'm no longer speaking for the committee, but reflecting on the process that we had. So great to see you on the panel, Alistair. Alistair was the first chair of the first Public Health Advisory Committee. And we have certainly tried in the work that this version of the committee has done to pick up on that earlier work and to carry it forward. And there's a connection that I'll allude to in a moment. We were created as a committee by the Pai Ora legislation. And part of the job of the committee is to produce a major report every 12 months. So the first one was on the food system, food environments. This report was on determinants, and the committee is about halfway through its next report, which is on primary care, the future of primary care, and how it can best contribute to public health. So the starting point really for this report was the 1998 report by the National Health Committee. And many of you on this call will have a copy of the light blue book behind you on your bookshelves, or at least know what I'm talking about, because it was a report that carried a lot of clout and sway. And while it probably wasn't news to any of us working in the public health field, it was news much more broadly, and brought the concept that health outcomes were closely connected to all of these factors that lie, in fact, outside of the health sector, to a wider audience. For all of us who are involved in writing reports from time to time, there is kind of an existential question that we sometimes ask ourselves and sometimes avoid, which is, what difference has our report made? And so to some degree, what we tried to do with this report was to answer that question in relation to the 1998 report. So our organising questions were, are the determinants that were identified back in 1998 still the same, or have some vanished or become less important? Have some become more important? The second question was, given that we've known for more than 25 years what these major determinants of health status are, how good a job have we done at using that knowledge to improve things? And then the third question, perhaps assuming an answer to that second question, was if the answer to the second question is that we could have done a better job, how might we do a better job in the future? So the answer to the first question is all of the determinants that were identified back in 1998 are still determinants of health. But there are some new ones, or some ones that were perhaps underexplored in 1998. And Sudhvir's just mentioned a few of those, the commercial determinants of health, and what WHO's report has called the mega trends. So climate change and other environmental mega trends, biodiversity collapse, for example, and also the impact of new technologies, and in particular AI, over these last couple of years, are new things which we explore in the report. The answer to the second question is that since 1998, life expectancy has increased for all ethnicities, but inequity between ethnicities has largely remained the same. It's the life expectancy gap between Māori and Pākehā has narrowed very slightly, but the life expectancy gap between, I guess, Pālangi and Pasifika peoples has increased somewhat. So not a lot of evidence of systemic improvement there. And those improvements in life expectancy have been largely the result of improvements in health care and to some extent other factors like the lower rate of smoking tobacco products. So the improvements that we've seen in life expectancy have not been the result of systemic improvements in the determinants of health that were identified in 1998. Indeed, when we looked at all of those determinants that were identified in 1998 and gleaned the information that was available about them, and I should say that one of the indicators of a lack of systemic response was that there hasn't been a determined effort to collect and collate information about those determinants in a systematic way since 1998. So there was quite a job, in fact, pulling together data to be able to answer these questions. But the data that we were able to collect suggested very strongly a mixed pattern. So some things had got better, some things had got worse. Even those things that had got better tended not to have shown an improvement in inequity. So in other words, you saw very often a kind of railway lines kind of picture where the same trend might apply to all ethnicities, but the lines were not getting closer together in any sort of measurable or significant way. So very mixed pattern. Some things have got worse. So you'll recall that from 1998, that housing was a very significant determinant of people's health outcomes, and across pretty much all of the indicators for housing as a determinant that we looked at, such as overcrowding or affordability, those showed that actually particularly for those with the lowest socioeconomic status and minority ethnicity status and for Māori, that those had got worse. So not evidence of systematic improvement there. And in fact, as I say, this mixed pattern suggests that no government has really sat down and said, what do we know about what's driving the determinants of health? And as a tangent, I should say, the determinants of nearly every other significant well-being outcome that we ought to be concerned about as a society. How might we systematically improve those things? That the evidence does not support that is what governments have done. And so that mixed pattern suggests instead that improvement has been the result of other factors rather than political determination. There was one area where we did see evidence of a government, or in fact cross-government agreement to improve something that was an important determinant, and that was child poverty, where we saw rates of child poverty becoming worse over time, and then for a period that corresponded pretty roughly with the last Labour government, improvements in child poverty, and now those rates leveling off and starting to increase again. So for just that brief period, while there appeared to be government determination and cross-party support for doing something about that important determinant, politicians were able to demonstrate that, in fact, improvement was possible. And so we would conclude that improvement ought to have been possible across other determinants also. So, in a picture that says we could have done better, how might we do better in the future? We have three, although in fact I call it four broad areas for improvement that we thought were important. We did literature reviews. We talked to lots of key stakeholders across many stakeholders and across communities, across iwi. We looked at evaluations of programs, so a pretty systematic approach to finding evidence in a variety of forms for what might work better. The first conclusion was we should be empowering communities. And those of us familiar with the Ottawa Charter, and I expect that's everyone on this call, will not be surprised by that conclusion. We've known for a long time, actually, that there's a secret sauce about putting power and control in the hands of communities themselves. But governments are pretty reluctant to do that because it involves handing over power and control to someone else, and therefore political risk. But that's what they have to do. So we're saying that government has got to resource iwi and communities to be able to identify solutions to the problems that they face and to lead those solutions. Resourcing is not just money, it's also information, it's access to other models that have worked somewhere else, and it's also about access to decision makers, so resourcing in those ways. So government does that, and then it steps out of the way and follows the lead of communities. There is, however, an area where government does need to do some work of its own, and that is around ensuring that the work that government does do, it does in a properly intersectoral way. And despite all of the rhetoric about whole of government and working across silos and all of that sort of thing, government has proved to be stubbornly terrible at doing this. And part of this is a hangover from the 1980s, where the Public Finance Act and the State Sector Act were in fact written to prevent intersectoral collaboration. Those legislative obstacles have largely been removed now, but still, those in Wellington at the ministerial level and at the chief executive level are very focused on their own silo at the expense of working with others across silos. And so, it's interesting. We discovered through the locality pilots that, in fact, at a local level, it was easily possible to obtain support from government officials across silos for initiatives led by communities and by iwi. But when information about those projects went up the chain to Wellington, the answer that came back down was pretty well inevitably no. So it's in Wellington that problem needs to be fixed, and we're saying it must be fixed. And we think that someone like Brian Roche ought to be interested in that, because he ought to be interested in making government better able to achieve its objectives. and this is something that is fundamentally necessary. There's a third area, which is also an area that only government can work on, and we called it. We used a metaphor. I don't know. We got tired of Dahlgren and Whitehead's rainbow, and so we've used a metaphor of tōtara growing in the forest of Tāne, um, and um, and we've talked about what we call a bedrock layer, and which is equivalent to the structural determinants that Sudhvir has talked about in relation to the WHO report. And these are like the determinants of the determinants. So when we think about, income, employment, education, housing, the things that we've always thought about as the non-health sector determinants of health, those things are in turn determined by other deeper things that we've called the bedrock. And um, our report talks about nurturing the bedrock. And whenever I say that phrase, I know it's wrong. You don't nurture the bedrock, but the bedrock is hard to change, but it is possible to change it. And the bedrock in this case is Te Tiriti o Waitangi. So actually honouring Te Tiriti, bringing about constitutional change to reflect Te Tiriti, that is something that is necessary for us to be able to permanently improve those determinants. We talk about deep respect for human rights. Again, that's an analogue for what's in the WHO report. If you think about all of the human rights instruments to which Aotearoa is party, only a few of them are properly reflected in our domestic legislation. And then the final area that we identify as being important is to look for win-win solutions. And that's explored this is not rocket science. It's explored heavily in the report itself, particularly in relation to AI and in relation to climate change. So that's all for now.
Thank you very much, Kevin. Again, we might be able to get to some questions, so put them in the chat if you have any. Thanks very much for that, Kevin. We'll go to the panelists now, starting with Professor Alistair Woodward. Alistair is an epidemiologist and global public health researcher at the University of Auckland. He's served as an advisor to the World Report on Social Determinants of Health Equity, as you heard, bringing decades of expertise in environmental health policy and equity-focused research. Alistair, as an advisor to the World Report, what do you see as the most important new insights or shifts in thinking since the original 2008 report? And the second part, how can we ensure this new evidence and framing actually translate into meaningful action here in Aotearoa and across the Pacific?
Thank you, Colin. And thank you for those introductions, Sudhvir and Kevin. Thank you very much. Kevin, you reminded me of the very first Public Health Advisory Committee and the report that we prepared on social inequalities. We didn't use the equity word then. I remember debating Bill English on the question of why should we be concerned about inequality. And he said, why should it matter? I mean, it helps height. And he said, I'm a little bit on the short side myself. He had a great sense of humor. But it's great to see the progress we've made, and disappointing at the same time to get the sense that some of that skepticism that was displayed in the early 2000s is returning these days. Colin, you asked what's changed since 2008? The Commission report that came out in that year, the global report that's just been published, and I suppose there's been progress, and I mean Sudhvir and Kevin have both referred to that there have been many improvements, particularly between countries, which is interesting, more so than within countries where the pattern is much more inconsistent. But that progress is not fast enough to meet the targets that the Commission set in 2008, and others have set targets since then. Um, I I thought the report, it was interesting and helpful and insightful in terms of reflecting on levers for change. You know, compared with 2008, there are new opportunities and new ways of thinking that do potentially provide opportunity for change that hadn't occurred to us 20 years ago. Um, I think the naming and focus on commercial determinants is really important. It wasn't so clear, 20 years ago, but it is apparent, I think, that this is something that we really need to wrestle with and think of a clear response. Um, there have been agreements both internationally and locally that have provided the sort of machinery or framework for change. I'm thinking of the Paris 2015 Climate Agreement. I'm thinking of the New Zealand Climate Change Act, which are both to do with climate change, obviously, but that's an example of more general changes, which I think have been hopeful. But at the same time, there've been negative um, consequences, haven't there? And I don't think this is discussed in the report, but it's terribly true that the kneecapping of international development, many countries, not just the United States, others as well, have slashed their funding for international development. WHO support is precarious. So even institutions like WHO that we've taken for granted a little bit in terms of mechanisms for change are perhaps facing a more uncertain future. Um, there are improvements that have occurred in the physical environment. Um, Anybody who's been to China recently, and comment on the absolute transformational changes in air quality that's evident, particularly on the East Coast. There have been significant improvements in terms of water supply and waste disposal, the WASH um, envelope, but also significant deterioration in biodiversity and climate change, extreme weather. Those things have already been mentioned. So I'm going a little bit outside, Colin, the reports themselves, but just thinking about the environment that we're working in. Another thing that struck me about the most recent global report is the focus on COVID-19. I mean, there was a signal event, a real setback, but one would hope also an opportunity to learn both about the overall impact and also the way in which it was differentiated between countries and within countries as well. The UK inquiry into the COVID response has come out recently. New Zealand is also going through a review of what happened with COVID. So here's an opportunity to think closely and hopefully learn from the past. Do you want me to stop there, Colin, before I move on to that question of global to local?
We finish off, Alistair, that second question, and then we'll go to Boyd. We're running a bit tight on time.
Yeah, sure. Well, look, jump in if I'm wandering on too long, Colin. Yes, that's a very interesting question. I mean, it is a global report. It's a treasury of, analysis and thought and case studies. but the question is, what about when we try and translate that locally? Here are one, two, three, four reflections I've got. One is that there are different aspects of equity. Equities, when you drill down and think about local action, often the question of what's fair is not absolutely straightforward. And Sudhvir referred to the work that Kirsty and I did with Sudhvir and Kumanen, which was trying to understand just how equity, the ambiguities of equity can unfortunately lead to policy paralysis. And we were trying to chart a way through difficult ground. In a nutshell, I think the point is that there are equity implications both of exposure or the source of the harm, and there are also often important equity consequences of the way we respond. And in the case of climate change, it's the effects of climate change on health and health equity, and it's the consequences of climate action on equity. And they may not run in the same direction, so we've got to think carefully about how to respond. I think this is a very local reflection, I suppose, but I think we've got to watch out for this argument that I guess we're all familiar with now, that equity is cause to abdicate responsibility. It's not fair that New Zealand should bear any burden of climate action because we're so small and we contribute such a small fraction of all greenhouse gas emissions. Now that's an unhelpful view, apart from the question of whether climate action really is a sunk cost or an investment. And all this ducking and diving to avoid taking responsibility leads in absurd, or might lead in absurd directions. Why should people in Oakuni pay for the cost of carbon, given that most of New Zealand's emissions come from Auckland? It goes on and on forever. So I think we need to shift attention when these kinds of arguments are raised to the point of sharing effort. We've all got a responsibility. The question is, how do we fairly and effectively share the effort that's required in order to respond to problems of that kind? Number three, health inequalities require action by sectors other than health. That was just so strongly demonstrated during COVID, wasn't it? That of course, health had an important role to play in terms of protecting the most vulnerable, but it was also a concern for transport, for education, for housing. But those sectors didn't always pick up the challenge, unfortunately. And then my last point, I've been quite taken by the advice about how we talk about these difficult problems from people like Jess Berenson-Shaw and Nikki Hare, who say we should take care to balance our tales of doom with tales of joy. If it's all about the problem, then people feel disengaged. So let's mix both, explanations for why action's required about health and equity with some stories about achievement. And some of those have already been mentioned. I think the housing story in New Zealand, the work that Philippa and others have done on housing improvement, physical changes to housing fabric, and the substantial changes that can be made. Sudhvir referred to the International Conference on Urban Health that was held last week. Skye Duncan, who's a New Zealander and a senior person in the Bloomberg Urban Initiative, gave a fantastic talk on city improvements and streets for people, and the examples of big changes that have been made all around the world to improve the quality of urban living, not just for those who can afford better access and better facilities, but for everybody. And then thirdly, I think on the climate change story, I think the potential to replace fossil fuels with renewable energy. There are just so many examples emerging of what can be achieved, and the UK, first country into coal, first country out of coal. You know, the exit from coal is not the only reason, but in 2024, greenhouse gas emissions in the UK reached the lowest level since 1879. 1879. Um, so I think there's lots of challenge around, but also there's a bright side to the story, and let's not forget that.
Thanks, Alistair. More tales of joy and less tales of doom is a good place to stop. We'll go to Boyd now. Professor Boyd Swinburn, internationally recognized expert, research interests in action to prevent obesity and reduce what he has coined the obesogenic environment. Currently co-chairs the Health Coalition Aotearoa, advocating for stronger public health policy, accountability, and action to address inequities across Aotearoa. Boyd, over to you.
Sure, thanks, Colin. I'm going to stick to my professorial stereotype and show a few slides, but I'll try to keep them brief because I know we're running out of time. Congratulations, Sudhvir and others. Gee, there's a long list of extremely important heroes in the whole health equity space that have contributed to this report. So congratulations on that. And I'm just going to focus on a part of it, small part of it, which is about harm products and the barriers to action, and more importantly, a couple of examples about how we're trying to overcome those barriers. So focusing on the commercial determinants, profit only purpose, the license we give to corporations to externalize all of the negative consequences, and of course their economic and political power, but also the political determinants. And we're striking this at the moment, particularly with the ideology that dismisses equity and dismantles any efforts to try to reduce it, as we've seen in this government in the last couple of years. Policy inertia on harm products. As I said, the first thing is the industry opposition. That's why we struggled to get policies through lobbying and regulatory capture. And then the government reluctance to regulate and tax, this kind of chill effect, unwilling to do battle with the industry and so on. But there's a third problem creating the policy inertia, which is where we need to focus on, and that's kind of the lack of demand for policies. So if you take a poll of people in the street or whatever, you'll find that they are supportive of these policy actions. But this is not translated into pressure for change. And so, in other words, this is a power issue, and that's really going to be the focus of what I want to talk about. So accountability is all about power. Responsibility is about you taking responsibility for yourself, but accountability means somebody else has power over you. And so what role do we in the civil society and academic space, what power do we have in this accountability cycle? Well, if government isn't setting the account, saying we're going to be responsible for these and held accountable for various changes, then I think civil society can make those, and we do make those. There's a lot of countdown type of activities happening where we decide what society needs. Taking the account, we do that perfectly well as researchers. We do that all the time. That's not a problem. Sharing the account, Alistair just mentioned Jess Berenson Shaw, how we communicate this, the goods and the bads. The fourth step is where power comes in, and that's actually holding to account. And civil society has power, but only if it's applied collectively. And if somebody wants to do anything about it and respond to the account, then we'll jump in and help them. So I just want to give a couple of examples. The first is the Informus group that we started in in 2012, 13 years ago. And a couple of weeks ago, we were in Mexico to review the Decade 2 about how far we've gone. So this is about academics using their expertise, applying it to food environments, doing the measurements that are policy relevant so they can be used for benchmarking and accountability. So this is the framework. I'm not going to go through it, just to show you that we've developed lots of tools for measuring not only government progress and the private sector policies and actions, but also tools to measure food composition, labelling, promotion, provision, and so on, so we can do that measurement for accountability. And when we look back over the last 12 years, this has been pretty successful. It's been picked up by about 70 countries, 600 odd protocol implementations, and so on. So in the academic sense, and it does show there's a value and a need for these policies for academics. So this last couple of weeks, in terms of Decade 2, we've definitely updated protocols and included new methodologies. But importantly, we're joining up the NCD, the obesity NCD world where we've come from, with other like-minded groups, so that we can kind of link arms and increase power. So in the food space, this links up under the global syndemic framework and joining up with undernutrition and climate change and sustainability, and then building capacity for a stronger translation of evidence into policy. And we find that these areas are really where academics are wanting to join up and contribute and so on, to be able to make better progress in the work they do in research, translating that into policy. So the second example I want to give is Health Coalition Aotearoa, which kicked off by this group of people in about 2018 for collective efforts to improve health, to get fairer outcomes and protect children. So lots of groups, as is typical in many countries, lots of little groups, NGOs, academic groups, professional groups, all calling for various things, all running around with their own voices, which is important to have multiple voices, but importantly, no coherent single voice, and usually quite under-resourced. So Health Coalition Aotearoa has really created the platforms for collective action. So if you provide this platform, then organisations and people can join and contribute through a membership approach. They can lend their legitimacy. We've got 70 odd health organisations that are members of Health Coalition Aotearoa. That's where we get our legitimacy from, our energy, expertise and funding from philanthropic sources. By coming together, and we've got 4 expert panels around tobacco, alcohol, food and public health infrastructure, you're creating a platform whereby experts can say, okay, here's all of the things that we could ask for in policies. What are the top 3? And that's a job of work. And you do need platforms to bring people together to get as much coherence as you can. And then communications with the collective voices is critical. Prevention briefs and BIMS briefings soon, coming ministers' position statements and so on. And then for a couple of areas which we reckon are really high profile, we've picked out doing campaigns. So school lunches and lobbying are the 2 areas. So Health Coalition's done a lot of work. We're based on Te Tiriti and our responsiveness framework. We put out this prevention brief for the top priority policies before each election. We ask the political parties the degree of support that they have for each of those policy areas. And you can see that National and ACT, who are in power now, are keeping to their promise of not doing anything for these harm products. In fact, they're taking them backwards. So they have kept their promise in that way. Briefing to the incoming government, policy briefs. This one's around junk food marketing to kids. All of this takes coordination and inclusion. The policy, the campaign brief for levelling the playing field, and all the work we're doing with principals and schools. So all of this takes quite a lot of effort, and it does take funding. So I think that improving and the reducing this policy inertia to improve health equity, what we've got at the moment reflects the current dynamics, the power dynamics over the values, economic policies, and economics, and we need to play in that game. Power doesn't concede anything without demanding it. From Frederick Douglass, the abolitionist from the US. We need the collective action of civil society. I think this is the only plausible mechanism to overcome this policy inertia. If we can muster the power and get at that fourth part of holding to account, I think we can get these changes. And academia has a really powerful role to play. Yes, we do all the nerdy stuff, but if we orient our research to policy relevance, we use our authoritative voices, we're in very privileged positions in universities and using that to the maximum. So time to get organised. Thank you very much indeed.
Thank you, Boyd. Some very helpful suggestions there for you. And of course, the good work you do with the coalition, hence your recognition recently of being a very powerful advocate. Great job. Thank you. We'll come now to Dr. Corina Gray. Corina is a public health physician and researcher with a focus on equity, population health, and evidence-informed policy. She's currently the Director of Public Health, and we'll come to you now, Corina.
Thanks so much, Colin. And kia ora koutou, everyone. I see lots of familiar names online. Great to see so many friends. I just really want to acknowledge Sir Colin and the team from Te Poutoko Ora Kiwa for organising this webinar, and also to Dr. Sudhvir for all your work on this really amazing and comprehensive report. I would encourage everyone to have a read. I don't have too much to add. I really just want to acknowledge all the speakers. Kevin, thanks for all your work on the FAQ. I know you'll be going on to other opportunities, but really the report Determining Our Future is a must read for everyone. Also Professor Alistair Woodward, I mean, you're a stalwart in the climate change space, and thank you for reminding us that we need to focus on tales of joy rather than tales of doom. And then finally, Professor Boyd Swinburn, you know, all your work in the obesogenic environment space, and also for reminding us of the importance of actually measuring the impact of the actions that we take. I just really want to emphasise the importance of collective action and of supporting communities to enact their actions. I know that COVID did highlight inequities, but it also demonstrated the power of communities and what happens when we can support and resource them. So I would just like to offer the last few minutes to people for questions. Colin, they don't probably want to hear from me, but yeah, just thanks everyone for all your great presentations.
Yeah, thanks, Corina. I'm not sure that we're able to do much, but I don't yet see any questions on the chat. But let me say this. Firstly, to all of you who have turned up, I think we were a little ambitious in having great stars all lined up. So lesson number one, not to have too many good people speak in one session. But look, I want to say thank you to all our speakers. This is obviously an ongoing challenge. But I was thinking, if New Zealand was a pupil in school and you are the parent receiving the report from school, what do you think that report would say? My assessment is this, that New Zealand is not the best in class. Secondly, New Zealand is not the most improved pupil in class this past year. If anything, New Zealand has been misbehaving and got into trouble on a few occasions. And so the summary report might go something like this: an earnest student, but could try harder. So, ladies and gentlemen, we hope that we've brought to you some very informative speakers, clearly a challenging topic to Sudhvir, who had oversight over that tremendous report. I guess I worry about WHO reports of this type: a lot of energy, a lot of good ideas, a lot of time, a lot of effort, but they kind of fall over at the try line. You know, it's like getting the ball to the wing, pardon me for using the rugby analogy, and the wing drops the ball on the line. And New Zealand can be a bit like that. So I'm encouraging us all to re-examine what we do and how we do things. Kevin, I think your the report is fantastic work. A little worried, of course, you're handing the baton on to an unknown. So we've got to keep an eye on this. And of course, Alistair and Boyd, for your fantastic contributions. Jude, I notice you're still awake. Thank you, everyone, for joining us today. If you do have any burning questions, we'll endeavor to come back to you offline, given that the chairmanship has been poor and we've run out of time. So thank you very much, everyone, for joining us today. Thank you.